Hello, welcome to the programme with me, David Foster. The enemy may be retreating, COVID forces not winning so many battles, but in The Art of War 2,000 years ago, Sun Tzu wrote, "Look out for signs of the enemy's behaviour and interpret them to understand the enemy's weakness." So, how far have we come in understanding anything about this coronavirus? Does it have any weaknesses? Very good to have your company on this roundtable. 6 months on from the first signs of an outbreak in China, we will be talking to experts who've spent that time trying to find chinks in COVID 19's armour.
It's been 6 months since the World Health Organization got the first reports of an outbreak of a new coronavirus. After appearing in Wuhan in China, within weeks people in other countries were being affected. As more was discovered about this new respiratory disease, it was given a name: COVID-19. Since the outbreak began, there have been more than 10 million cases and more than 500,000 deaths, numbers that will continue to rise over the coming years. To slow the spread of the pandemic, measures such as lockdowns, border closures, and self-isolation were imposed, while scientists scrambled to learn more about the disease, how it was passed on, how best to prevent it, and who is being worst affected. In just half a year, the pandemic has already caused widespread suffering and significant economic damage, and concern about the future is growing. So what exactly have we learned about COVID-19 over the past 6 months, and what comes next?
Well, let us say hello to Sian Griffiths, Professor of Public Health and Primary Care at Chinese University of Hong Kong, who happens to be in France. Gisli Jenkins is with us, a professor at the National Institute for Health Research, also joint editor-in-chief of the respiratory journal Thorax, and Dr. Ann Marie Kimball. She's in Seattle on the west coast of the US, epidemiologist and senior consulting fellow for the Center on Global Health Security at Chatham House. Experts gathered together. So, Shawn, welcome back to the program. You were with us when all of this started. I want to ask you what you have learned, or the scientific community in general has learned, that we didn't know when last we spoke.
This is a disease that we don't know about still. Over the last 3 months, obviously, we've learned a lot more about how infectious it is, how difficult to control it is, how we can get re-emergence once we thought we'd controlled it. So this is a very worrying global pandemic. I think 3 months ago, we weren't sure how far it would spread and how profound a problem it would cause. In the UK, we know that it has affected older people, and we've had a particular poor record in care homes, and we've seen a large number of deaths in care homes.
You see, a lot of that, Shawn, if I may butt in, is in the public domain. It's in the newspapers every day, but we don't read about the scientific progress necessarily that has been made in trying to identify what makes this virus so dangerous, so special. So scientifically, what would you say is new?
Scientifically, we know that the illness responds to certain drugs, such as dexamethasone. We've seen the randomized controlled trials run out of Oxford, looking at various treatments. We have learned that hydroxychloroquine is not necessarily useful either in prevention or in patients who are on ventilators. We've learned that it's been possible to speed up vaccine production way beyond the sort of levels we would have said in the past. In the past, I think when we talked about SARS, that after SARS, 4 years would be quite a quick time within which to have produced a vaccine, which actually never occurred. But look at us now with vaccine candidates in the UK, in Germany, in China, in the US, trials in humans, and novel ways of producing vaccines as well. So I think that the advances in science have been tremendously rapid. over this time. And partly that's because there's been good global collaboration, good international collaboration.
Okay. Well, you would know about SARS because you co-chaired the inquiry into it. Let me come to you, Gisli. Your specialism is the respiratory tract. We're talking about ear, nose, throat, and that is the means by which we think the virus gets into the human body, possibly also through the ears. You might tell me I'm wrong on that one, but are there other means for it to enter the body? Let's say I cut myself and the virus entered into my bloodstream. Is that possible, or is it only down here?
Well, as far as I'm aware, the commonest route of entry is through the upper airway and through the oropharyngeal mucosa, as well as the eyes. What we know from single-cell sequencing data are that the major receptor for entry of SARS-CoV-2, the virus that causes COVID, is via the ACE2 receptor. And the highest levels of expression of ACE2 are in the conjunctiva, which is the lining of the eye, and in the mucosal surfaces of the nose and the mouth. So it's most likely that it's through that route. So it's very unlikely that if you cut yourself, you'll be able to get it through the blood. And we haven't demonstrated that yet. It's probably not impossible, but it's much more likely that if you touch the virus and then put your hand to your mouth, to your nose, or your eye, that you're going to cause an infection through that route.
There was an article, Gisli, in the New England Journal of Medicine, the headline of which was something like, "Some scientists suspect that COVID-19 causes respiratory failure and death, not through damage to the lungs, but the brain, and other symptoms include headaches, strokes, and seizures." Since the lungs are one area that you study in particular, what do you make of that theory?
Well, there's definitely evidence that the virus can affect multiple organs. Surprisingly, there's actually very low levels of ACE2 receptor actually deep within the lung, within the alveoli. There's much higher levels of ACE2 receptor in the kidney and in the gut, for example. And we do know that kidney failure and gut disease can occur as a result of infection. I'm not clear on receptor expression in the brain, but cognitive function, fatigue, and neuropsychological features are major symptoms associated with COVID-19, and that's emerging all the time. The mechanism by which that occurs is as yet unclear, but it's definitely a problem.
Ann Marie, let me bring up something that's been said by Mark Woolhouse, who's Professor of Infectious Disease Epidemiology at Edinburgh University. And he says that having lived with COVID-19 for 6 months now, the most important thing we've learned is that we're going to have to live with it for an awful lot longer. Essentially, we are 6 months into a lifelong relationship. True?
True. Unfortunately, our efforts at containment, at least in the United States, have not been completely successful, and even our efforts at mitigation. It looks like this virus can resurge, if not completely eliminated from a population. And so we're seeing it. I mean, basically what you're looking at is if COVID-19 persists with high prevalence in almost any corner of the world, all the countries are at risk because of our travel patterns and our close, transportation between nation states.
Isn't there perhaps a certain irony here? I mean, you authored a paper or a book called Risky Trade, Infectious Diseases in an Era of Global Trade. This terrible disease has gone around the world so fast, perhaps because of this, but in its own way, it might actually cause a slowdown in global trade as a result, and therefore not re-emerging quite the same way.
We're already seeing quite a major slowdown in global trade in merchandise and services. I think the most recent statistics suggest almost a 13-14% drop. And that's highly unusual because we were definitely on an ascending curve. And so at this point, I think you're very right. We could well see a real drop in global trade and transportation and commerce. And I think that's going to be a major part of what we'll face.
Let's go back to Shawn, and of course, any one of you can say whatever you like at any time. Don't wait for me to ask a question. Shawn, is the virus mutating in such a way that it is almost impossible to nail down its exact composition?
I'm not so sure it's the mutation that's the problem. The problem is that it spreads and can spread asymptomatically and can infect large numbers of people. And so it's the infectiousness that of whichever strain you seem to have around at the moment that is the key issue here. How do we actually detect the virus in populations and make sure that we can test, isolate, trace, do the contact tracing, and stop that chain of transmission? And that remains the biggest challenge we have at the current time. Whatever the virus, we need to stop the spread, and that means that we have to put those non-pharmaceutical interventions into place. And we have to remember all those other things that we've been talking about all the way through the pandemic. It's about social isolation, it's about hygiene, it's all those issues remain very important because we have not managed to stop the spread of this disease or its reemergence, even in places that have done quite well.
Gisli, I'll come to you in just a moment, but let me go back to Ann Marie. You mentioned the number of countries, the number of territories that could be infected. Is it getting worse in those areas that didn't make the headlines in the beginning? I mean, you worked in parts of South America. I know it's been bad in Brazil. You're working at the moment on cases of this and other diseases in West Africa. You're an expert in the Far East. What is the pattern for travel of this virus?
Well, I think what you're seeing in Latin America is that Peru has definitely had a very major outbreak, still in the midst of it. And of course, Brazil, where we've had a sort of failure of leadership to acknowledge the problem within the population. So definitely Latin America is seeing very high cases. Mexico's being affected. As far as West Africa, I think you're seeing a little bit less. But, you know, again, diagnostics and access are always an issue in West Africa. But I would point out that in Liberia, for example, they feel that their Ebola outbreak was very formative in getting their systems up and being able to control infectious diseases. And I think you're also seeing the African CDC stepping up in a big way to assist the countries of sub-Saharan Africa. As you've seen, China has been quite successful, even with a resurgence. So a different story every region you look at.
But are you with Shawn and Gisli, perhaps, I don't know, he'll tell me in a second, in thinking that the kind of social restrictions that could to some extent stop this replicating itself in other human beings, those kind of restrictions, whatever they happen to be, are going to be something we are going to have to learn to put up with for as long as this disease is here?
I think for the foreseeable future, until we really have a definitive strategy to interrupt transmission effectively, yes, we're going to be looking at that. And I would also say those kinds of social distancing restrictions are very much more difficult in some populations, such as India and West Africa.
Gisli, you conducting follow-up tests with those people who have had the virus, who have left hospital. What, if anything, have you learned from that?
So what we're seeing predominantly is there are two major symptoms that people are suffering from in the longer term. One is fatigue and the other is breathlessness. The causes of long-term breathlessness are not clear at the moment. We need to look into that further as time progresses. But what we're worried about is the development of scarring. We know that in the acute illness, there's a profound inflammatory response, and indeed it's likely that the reason that dexamethasone works as a treatment is by dampening down that inflammatory response. And in some people, the consequence of severe inflammation of the lung is scarring. And in a smaller subgroup of those people, that scarring can then progress independent of the original injury. So what we're concerned about in the longer term is that people who have had this acute lung injury as a result of the COVID infection go on to develop progressive scarring as a consequence.
And in terms of how that helps you, other than in treating those particular patients, what do you learn from that?
Well, we learn that the infection has a lot of sequelae which are quite worrisome, and certainly it should make communities double down on some of the measures that we've been discussing, because it It's not a sort of one hit and you're done. This idea that if you have an infection, you'll be protected for life. That simulates some people to consider going out and getting infection, getting it over and done with. That would be a very bad idea, because there are potential long-term consequences to this infection, even once the acute infection is over. So it really does mean that we should take preventative measures very seriously. We should try very hard to control and, if at all possible, eliminate this infection.
Okay, and each one of you can jump in on this whenever you feel like it, but I'll kick off with Shawn. What is going to be the most important thing in the next 6 months that needs to be learned for people to be able to say, actually, we are getting on top of this?
It's going to be a matter of having the epidemiological information to know whether or not you've got disease in your community, and if there's disease in the community, to make sure you take the right steps. I mean, if we look at Leicester in the UK at the current time, we found in the UK that there has been an increase in cases in Leicester, which has required them to slow down on the release of lockdown that the rest of the country are doing. And that's been an important lesson. But also about the issue about Leicester is it is a particularly heterogeneous community. And we also recently just had the information about the Black and ethnic minority ethnic groups being affected more severely. So one of the lessons from that would be that we need to have extra protection and also make sure that we actually get our messages right in the community, to make sure that people understand why measures are being taken, or they're being asked to take certain steps, and that they understand how that needs to modify their behavior. And that's with us for the foreseeable future. There's going to be big confusion if we get a second wave in the winter, when we've also got flu. That's going to be really tricky to handle. And we're going to need to really make sure we've got the surveillance in place to spot where we've got outbreaks and make sure we can intervene appropriately.
Okay, Gisli, what needs to be known as soon as possible?
I would agree with that. I think what we really need to know is when people are getting infection, we need to know that quickly. We need to get the results of swab tests, PCR tests out quickly. We then need to be able to track, trace, and isolate those people as soon as possible. So as was said, we need to get the community involved. The community need to understand and trust the process so that we can isolate localized spikes of infection very quickly to beat the chain of transmission. It really does come down to that. And we've learned over the last 6 months quite clearly that the simple measures, face masks, 1-2 meter distancing, hand washing, these things really help. It seems trivial. It seems so trivial as to be almost unimportant, but the simple measures are really the most effective measures. Hand washing, face masks, keeping your distance. These are really important.
Let's go to Ann Marie. Martin Hibbard, you know of him anyway, Professor of Emerging Infectious Diseases, London School of Hygiene and Tropical Medicine. We might get it, that is the death rate, from 1% right down to 0.1%, in combination with improved testing and greater understanding of our immune systems and antibody level responses to COVID-19. Then I think we would find ourselves in a very different, much better position in 6 months. I am hopeful. Epidemiology, understanding it, know where it's going, know what you need to do.
I absolutely agree. I agree with the former speakers too. But I think the other thing we need to learn and we need to really exercise is our international serious collaboration. If we were to get a vaccine, for example, we need to have an equitable vaccine rollout plan for the most affected populations. And that plan isn't in place. What we've learned so far is that supply chain, making sure you have materials, good messaging, close coordination is really, really critical in fighting this virus. We're seeing now, for example, in our country, that younger people seem to be the major transmitters, although they are not the major mortality in our population. Older people are most at risk. So how do you manipulate your non-pharmaceutical interventions to interrupt transmission, knowing what you know about the epidemiology? We're starting to learn that school closures, for example, may not be critical. And those kinds of data are coming forward. The more we learn, the more we'll be able to effectively interrupt and stop transmission going forward.
Now let's go back to Shawn on this particular point, which is you talked about the black and ethnic minority groups being more susceptible to this. And you may remember I asked what some people might have thought was a daft question in our first program, which is what use are viruses? Since then, I've learned that without the millions, perhaps billions of viruses in the world that are not pathogenic, we as a species probably wouldn't survive for very long. And I also picked up that they've been part of our evolutionary progress, that there are something like 100,000 remnants of genes originating from virus in our human genome. I'm no expert in this, but I just wonder if there are certain physiological things that have come about through our evolution as a species, but in different parts of the world, that might make people more susceptible to the virus.
Well,
I remember.
can I just interject here, because actually,
Go on.
No, what you're probably seeing there, as much as a sort of inherent vulnerability, is you're seeing an exposure where in our society, for example, we had essential workers who were forced to work or allowed to work, if you will, during lockdown. Those are largely public-facing jobs, those are largely wage jobs, and those are largely jobs held by people of color. So you really need to pull out exposure versus vulnerability when you look at the difference. And certainly,
Ann Marie, I did do a program on this.
And Black populations seem to be at higher risk.
Yeah, I also put forward the supposition that, yes, okay, one understands that the frontline workers, a lot of them aren't necessarily very well paid. They are from BAME groups, but an awful lot of those people who are dying were middle class people who are highly trained, doctors, nurses, etc., etc.
Yes, that's true.
I think you'll find that from the UK reports, there were the two reports from Public Health England. The first was the descriptive epidemiology, which showed which groups had been most at risk of death during COVID, and that included elderly people as well as the BAME groups. But then there was a subsequent report from led by Kevin Fenton, who did a huge exercise of discussion with people of color around in many situations about what did they think were the contributing factors. And I absolutely agree with Ann Marie. There are a whole set of things about public facing jobs, but there are also things about structural inequalities in our society. And there is a huge link between inequalities in health and
so you don't think there could possibly be an inherited vulnerability? You think it is the situation in which one finds himself?
Highly doubtful, personally.
I
would go along with Shawn on this, definitely.
And the other thing that we found was that a lot of the people had comorbidities, and we know that particularly in some of our Asian communities, that diabetes rates are very high, and diabetes is a particular predisposing condition. So it's quite confusing, and I think that from the two reports that just came out in the UK, that there's a whole train of work now going to go forward, and I would guess that it'll be more about deprivation and structural issues in our society than about the genetic predisposition. But you can't.
Sorry, as we come towards the end of this, let me give the last word to you, Gisli. You're talking about people having to carry wounds, if you like, for the rest of their lives. But the retroviral, the antiviral drugs, they are going to be vital until we get a vaccine.
Yeah, I mean, clearly getting a vaccine is the holy grail. If we get a vaccine, life will be a lot easier for everybody. I think there are definitely treatments that are shown to work, which is great. The mortality rate is coming down, as we often see in pandemics, that the case fatality rates are high to begin with and slowly come down. And that's also great news that things do seem to be improving. I would agree with the other speakers that social deprivation is a key risk factor. Nothing trumps age, unfortunately. The older you get, the more susceptible you are. I would disagree, though. I would be very surprised if there weren't genetic determinants to this as well as social deprivation. There are in just about every other condition in life. There is a gene-environment interaction for just about everything The magnitude of the genetic interaction, we don't know yet, but I'd be very surprised if there wasn't one.
And how vital is it to know that?
I think the information is power. Whatever we can do to understand this virus will help us defeat this virus.
Listen, thank you very much indeed. I think one thing you probably all agree on, because I've read what you've said and I've taken in what so many other experts have said, is that this is probably not the last pandemic we will see, and perhaps we will be better prepared for one that comes along in the future. Thank you so much for taking the time to explain some of those unanswered questions, to add your weight to what has been said about this terrible disease and hopes of beating it. Thank you for coming on Roundtable, and thank you very much for watching this program. From me, David Foster, and from the team that made it all possible, we hope to have your company next time. Until then, goodbye.